Okay, so my presentation is going to be about the Milky death of Michael Jackson. And the reason why it's called Milky is because he died at the hands of a drug called propofol, which is a very lipid soluble drug. And it's so lipid soluble that it looks like milk, it's so thick. And this was a very famous case about how his uh, doctor's personal physician, Dr. Conrad Murray, accidentally killed Michael Jackson, who is referred to as the King of Pop. So before we get into the whole story over on the right side, we're going to start on the left side, where I'm going to talk a little bit about the drug that was determined to be the reason why Michael Jackson died. And this drug is called propofol. So this is the chemical structure here. As you can see, it doesn't have a lot of functional groups. It only has this benzene ring and a hydroxyl group coming off. And so let's talk a little bit about the history of propofol. So the reason why propofol was developed was because the medical industry needed a faster acting and a safer anesthetic than thiopental. Thiopental was the anesthetic that was being used prior to the emergence of propofol. And it lasted a long time. There were very negative side effects. And so people in the medical industry wanted a better anesthetic. So John Baird Glenn at Imperial Chemical Industries was the man who developed this drug in 1980. It was approved for use in the UK in 1987 and in the rest of the world 2 years later in 1989. So this is not a naturally occurring drug. It's a synthetic drug. And it was based off of its derivative 2,6-diethylphenol. And 2,6-diethylphenol was actually the first drug that was looked at by John Baird Glenn. And he was having problems synthesizing it, so he decided to use a derivative. And that derivative ended up being this right here, which is propofol. And this totally revolutionized surgical anesthesia because propofol has a very fast onset. Usually within less than 10 seconds, patients will be knocked out for surgery. The effects are short-lived, which means that patients aren't feeling sick for long afterwards, and there's only mild side effects. So a lot of advantages compared to thiopental, which was the original one. So let's talk about some physicochemical properties. Molecular weight is 178.273 grams per mole. It has a pKa value of 11. So physiological pH is usually around 7, so this proton most likely is going to be still on the oxygen, which makes propofol neutrally charged for the most part at physiological pH. As I said before, it's very lipid soluble. That's why it gets this milky appearance here, and that gives it a fairly high log p value of 4. So they were having problems delivering such a lipid-soluble drug into a vessel because it wasn't very water-soluble. So to get around this, John Baird Glenn decided to use a vessel made of egg lecithin, soybean oil, and glycerol, and this increased the water solubility so that the body could absorb the drug at physiological pH. The route of administration that's typically used to administer propofol is intravenous injection. There are oral formulations that are being developed by pharmaceutical companies, but at the moment, those are just in testing phases, and intravenous injection is the primary route. So let's talk about the mechanism of action. Propofol acts on the gamma-aminobutyric acid receptors. They're called GABA receptors for short. And propofol is an agonist of these receptors. So in this picture here, we can see right here on the alpha subunits is where GABA binds, and GABA is the natural ligand for these GABA receptors. Now, propofol binds to this beta subunit, and it's a positive allosteric modulator of these receptors. So what that means is when propofol binds, GABA is going to have a much easier time binding to this GABA receptor. And that's what I mean here when I say it helps facilitate the binding of the GABA molecule. So when propofol is bound, we're going to have a higher binding affinity for the GABA molecule and the GABA receptor. And what happens when GABA binds is it causes chloride ions to flow into cells. And this makes the cell interior more negative. And in physiology, this is referred to as neuronal hyperpolarization. And in order for action potentials to be triggered, there has to be a depolarization, which is positive charges are flowing into the cell. But this is doing the exact opposite. So in a way, this is preventing depolarization, and consequently, that prevents the formation of action potential. So we have a lot less synaptic signaling in the brain. And researchers believe that this reduced synaptic signaling is why patients experience loss of consciousness, hypnosis, and analgesia. There's also another receptor that propofol acts on, and this is the N-methyl-D-aspartic acid receptors, shorthand is NMDA. But unlike the GABA receptors, propofol acts on this receptor as an antagonist. So what this does is it prevents voltage-gated sodium channels from opening, and it slows the opening of calcium 2 channels. So this is in two ways preventing positive charges from entering the cell. So this is a further way of preventing depolarizations and preventing the firing of action potential. So you can see how this drug sort of shuts down synaptic signaling in the brain. So let's talk a little about dosage and toxicity of propofol. The standard dose that's usually administered to patients prior to their surgery or whatever procedure they're undergoing is 1.5 to 2.5 mg per kg. These values were found on the PubChem website. The TD low is 2.857 mg per kg in a day. The lethal dose, the low lethal dose is 386 mg per kg over a period of 14 days. And both of these were measured in humans. Now, these three at the bottom here were measured in chicks. So the therapeutic index for sedation is 31.4. Therapeutic index for analgesia is 25.9, and the therapeutic index for sleep is 10. Okay, so we've talked a lot about the properties of the drug, so let's talk about the pharmacokinetics and toxokinetics of propofol. So I'm going to talk about ADME, the absorption, distribution, metabolism, and elimination. So there's not really any absorption mechanism simply because propofol is administered via IV. Which gives it 100% bioavailability. So there's not a whole lot to talk about there. Distribution, the volume of distribution is reported to be roughly 3 to 4 times the total body volume of the patient. And it has a large volume of distribution due to its very high lipid solubility. It easily crosses the blood-brain barrier. And when it's in the plasma, it's extensively bound to albumin and erythrocytes, which are proteins found in the blood. It's reported that the free fraction of plasma protein is only 1.2 to 2.7%. So most of the albumin and erythrocytes have propofol bound to them in plasma. So one of the studies that I read described the distribution of propofol in the body as a 3-compartment linear model. So the first compartment is a rapidly equilibrating plasma compartment, and this is simply because propofol is administered intravenously, so it will equilibrate very quickly into the plasma. The second compartment is also fast equilibrating. It has a 1 to 8 minute distribution half-life, and this is when the propofol is transferred from the plasma to highly perfused organs such as the lung, liver, kidneys, and brain. And then from here, the third compartment is the slow equilibrating compartment. It has a 30 to 70 minute distribution half-life, and this is when the compartment reaches the central nervous system, the skeletal muscle, and the adipose tissue. So overall, as I said before, and I was talking about the advantages of propofol over thiopental, propofol has very fast acting effects. These effects don't last very long. It has a pretty short half-life, which means the recovery period is very short, and there's few hangover effects experienced by patients. So much more advantageous as compared to thiopental. So now let's talk about the metabolism. Here I have a picture of most of the possible metabolites that can be formed. Just ignore the top part here. I mainly want to focus on propofol here and then it turning into 4-hydroxypropofol via these cytochrome P450s. And then over here as well, when the UDP glucuronosyl transferase converts propofol into propofol glucuronide. So propofol is mainly metabolized by the liver, and 70% of the propofol that is ingested will be converted into propofol glucuronide by the UDP glucurosyl transferases, and then the other 30% is converted into 4-hydroxypropofol by cytochrome P450s. So most of it's metabolized in the liver. However, there is partial metabolization in kidneys, the small intestines, and the lungs. So here you can just look at the chart and take a look at some of the metabolites formed. So let's talk about elimination. Propofol is mostly eliminated by the glomerular filtration in the renal system. It's pretty quickly eliminated. 73% of the dose is eliminated in 24 hours, and nearly 88% is in 120 hours. And the renal clearance is about 120 milliliters a minute. The main metabolites that are removed by the renal system are the water-soluble glucuronic acid conjugates of propofol. So those are all of these at the bottom. So this is a glucuronic acid conjugate. So is this. So these are the ones that are going to, these are the main metabolites that are removed. Okay. So now let's move on to the actual story. This is very famous, but I'm just going to go over the details. So this is the day that Michael Jackson died, June 25th, 2009. This was truly a tragic day for the lives of many people. He was a pop icon. Many people knew him. Many people loved his music. So this really hit society pretty hard. Now, a cocktail of medication. So MJ had been struggling with sleep insomnia for months, and he was taking a wide variety of drugs to help him sleep. In addition to propofol, he was taking 4 different benzodiazepines, which were lorazepam, midazolam, diazepam, and nordiazepam. And these drugs were given to him by his private physician, Dr. Conrad Murray. Now, on June 25th, 2009, after giving MJ propofol and all of these benzodiazepines throughout the night, Dr. Murray found Michael Jackson unresponsive in his bed with a weak pulse at about 10:30 that morning. He had began CPR, but his CPR attempts were failed, and he called 911, and paramedics continued CPR efforts on the way to the hospital, but unfortunately this was to no avail. Michael Jackson was pronounced dead at the Ronald Reagan UCLA Medical Center, and the LA County coroner determined that the cause of death was acute propofol intoxication. This was the main reason. Now, they did list that the benzodiazepines were believed to have contributed somewhat to the death as well, but propofol intoxication was listed as the primary cause of death. And they believed it caused respiratory failure and cardiac arrest, which is what killed Michael Jackson. After an investigation and a trial, Dr. Murray was convicted of involuntary manslaughter and served 2 years in prison. His original sentence was actually 4 years, but he was well behaved in prison, so they let him out 2 years early. Now, during the trial, Dr. Murray claimed that he had given Michael Jackson a 25 milligram dose of propofol that was mixed with lidocaine, and this was on the morning of MJ's death. Now, the reason why it's mixed with lidocaine is because propofol can be very painful when it's injected, so lidocaine sort of numbs that pain as the propofol is being injected. And Dr. Murray also said that earlier that morning he had received 10 milligrams of diazepam orally, 2 milligrams of lorazepam via IV, and 2 milligrams of midazolam orally earlier that morning. So MJ had a lot of drugs in his system, especially these benzodiazepines. So let's do a fact check. I did a lot of research and read the reports and read studies on propofol and the whereabouts of MJ's death, and I concluded that it's very unlikely that Dr. Murray only gave Michael Jackson a 25 milligram dose of propofol. This is simply too small of a dose to kill somebody. The typical therapeutic dose is usually 2.5 mg per kg. You can do the calculation. MJ weighed 60 kilograms at the time of death, which means that if he was given 25 milligrams of propofol, the dose given to him was only 0.42 mg per kg, which is much, much smaller than the typical therapeutic dose. And I find it very unlikely that a dose of 0.42 mg per kg could have induced respiratory failure and cardiac arrest. I also, based on the studies I read, MJ likely had a tolerance to propofol because he had been taking it every day for nearly 2 months. Now, numerous other experts and doctors said that if MJ had kept up his propofol use, he eventually would have died anyway. Because taking a very powerful drug like this for an extended period of time is very dangerous. But on this particular morning, it's very unlikely that the 25 milligram dose of propofol killed MJ. So the conclusion I came to is Dr. Conrad Murray is lying about the dose of propofol he gave to MJ on the day he died. The dose was likely much higher than 25 milligrams because if it's 0.42 mg per kg and the standard therapeutic dose is 2.5, there's a big difference there, and I don't think 0.42 would cause MJ to die. So yeah, here I say 25 milligrams is too small a dose to induce loss of consciousness and death. Just some side notes to add. Dr. Murray administered propofol in a very unsafe way. He was at Michael Jackson's home where there was not adequate machinery to safely monitor the oxygen saturation levels of MJ's blood. So he was using a machine to measure the oxygen saturation, but this machine clearly stated that it is not for prolonged monitoring of patients. So, and also when administering these types of drugs, it's standard protocol to have respiratory support devices on hand in case the oxygen saturation level drops. Dr. Murray did not have these either. And there was also reports that he did not perform CPR with the right technique. And this is kind of interesting considering he's a doctor. He should know to perform CPR, how to perform CPR correctly. Apparently he was using only one hand, so he wasn't getting the full thrust of the two arms. And he was doing it he was performing CPR on Michael Jackson's bed. Now, you're supposed to do it on a very hard surface, so a lot of things were in question here, and it was also reported that he waited too long to call 911. In a CNN report, emergency physicians and paramedics believe that Michael Jackson was clinically dead for 30 minutes before Dr. Murray called 911. So a lot of things seem to have gone wrong here, and it seems as though Michael Jackson's death could have been preventable. And here I just list my references. So yeah, that was my presentation on how Dr. Conrad Murray accidentally killed the King of Pop with propofol. Hope you enjoyed it. Thank you.